Good morning, everyone. Good morning, or good afternoon, Julia. Thank you very much for once again to all my colleagues attending the Hepato Pernambuco 2021 Liver Talks. It's a great pleasure to begin this scientific event today with a liver talk, acute liver failure in the ACLF, a multidisciplinary management. It's also an honor to have my colleagues, Professor Rita Silva from São Paulo, who will moderate this roundtable with me, and will introduce the international speakers, debaters, and presenters of the clinical cases. My special thanks to Professor Arun Sanyal, who shared with me the roundtable organization, and will take Professor Rajender's place, and also to Professor Julia Wendon, who was a fellow with me at King's College Hospital, and now he's a professor of hepatology and the same unit. We also prepare a small tribute to celebrate the Hepato Pernambuco Silver Jubilee. Welcome to Penultimate Liver Talks 2021 today.
15 anos do IFP, Instituto do Fígado e Transplante de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
Good afternoon, everyone, and thank you, Dr. Leila, for inviting me for this Hepato Pernambuco Silver Jubilee and for the celebration of your 15 years of Institute of the Liver in Pernambuco. I have pleasure to introduce now Professor Julia Wendon from UK, which is a professor from the London and is a consultant intensivist on the King's College Hospital from the King's College of London. And she is going to present to us what we have learned about acute liver failure. Please, Professor Julia, the word is yours. Thank you.
Thank you so much for that very kind introduction, and especially thank you to inviting me. Leila, I enjoyed working with greatly, and it was no surprise at all to see what she's achieved. It's vast amounts, and I think we all stand back in congratulations of that. So to be speaking on the Silver Jubilee is a real honour. So I'm going to talk about acute liver failure. Fantastic, and that should now be on full screen.
Full screen, yeah.
Super. So I've got 15 minutes. I'm going to talk quickly. And mainly what I could say is, has much changed? We've probably got better at doing what we've always done. That is the main thing. And I guess for me, the main message of this presentation is that declaration of interest and enthusiasm and optimism. And that is pivotal to the practice of intensive care, but specifically in the management of acute liver failure. It's doing the small things well and pulling it all together as a team. But let's go through some of the areas that may or may not have changed a bit over the years. So the principles of intensive care, particularly liver ITU and acute liver failure, are to have an absolute focus on our patients and their families, to work collaboratively with our colleagues so we all get the best out of each other, to always discuss, to always be curious, and to throw out the tablets of stone by undertaking good research that changes practice. A lot of the slides that I'll use are lifted from the EASL clinical practice guidelines for acute liver failure, and the references there should you wish to look at it. And I'm happy to share these slides with colleagues. So has much changed? No, we still refer in terms of definitions to hyperacute, acute, and subacute, easily translated to fulminant and subfulminant, or acute, subacute, depending on whether one is in France, the UK, the States, or Japan. And that's really important. And the reason it's important is it relates to prognosis and risk of other organ failure. So if you look at someone with hyperacute and acute liver failure, such as this image on the left, this is acetaminophen, they have a profound primary liver injury, they are profoundly coagulopathic, deeply encephalopathic, and they have a great ability to recover spontaneously. By contrast, the image on the right is that of subacute liver failure, much more indolent, quite difficult sometimes to separate from acute on chronic liver failure. They often have a degree of portal hypertension, though on imaging you can separate them, and you can see these regenerative nodules and collapsed liver, and their ability for regeneration is profoundly limited. They have lower levels of encephalopathy. They don't, by and large, get cerebral edema, but in some ways their prognosis is considerably worse. And history is everything, as well as other investigations in defining etiology and type. So how do I look at the types of liver failure? Well, I probably have changed this over the years, and I would now separate these into the primary acute liver failures, the drug-related. Vastly more drugs are hepatotoxic, and we need to consider that along with DRESS, the viral hepatitides, the toxin-induced acute liver failures, the Budd-Chiari syndromes and the immune-mediated diseases, and pregnancy-related acute liver failure are really important. The extrahepatic ones that we ought to consider, and particularly because by and large transplantation is not appropriate in this cohort, the ischemic hepatitides, you need to manage the heart and the lungs. You don't need to transplant the liver. The systemic diseases, the macrophage activation syndromes, hemophagocytic syndrome, the infiltrative diseases with cancer or lymphoma. Those are all important and being cited on those diseases which have a chronic phenotype but present looking like acute liver failure: Wilson's disease, autoimmune, Budd-Chiari, and HPV reactivation. Here you see images on the left here, a ruptured liver in someone with pregnancy-related acute liver failure, a Budd-Chiari in the middle with clot in the hepatic vein, and aortoporto shunting on the axial imaging, and here HSV, herpes simplex virus, in a peripartum acute liver failure. So important messages: early transfer to a specialist centre that has large amounts of experience in the management of acute liver failure and can offer transplantation and potentially other supportive measures. The criteria that you see here probably still hold good for hyperacute and acute etiologies, and in the non-paracetamol, read subacute etiologies. Always intubate early. Always consider that ventilation for anyone with a falling GCS. Always look at the pupils, travel with fluid, travel with noradrenaline, and give bolus mannitol or hypertonic saline for pupillary abnormalities. We've got much better at this hub and spoke model now. both across Europe and in many other continents, such that these patients are transferred early with a marked improvement in outcome, whether you need transplantation or not. In terms of cardiovascular support, the primary drug of choice should be fluid, followed by norepinephrine, followed by low-dose terlipressin once you get to about 0.3 or 0.4 mics per kilo per minute. It's really important that you get this balance, as you see here on this little image, between organ ischemia and organ edema. That optimal fluid, it's a bit like making a souffle. When you know it's right, but sometimes you get it wrong. Think about alternative diagnoses. This is a 23-year-old presenting with a coagulopathy, INR of 7 times normal, elevated bilirubin, impaired conscious level, and hyperlactemic and hyperammonemic. He had acute viral myocarditis, and his acute liver failure was treated with VA ECMO. So again, always think about the alternative diagnoses. And in terms of fluid, this is a lovely slide. It's not mine. I borrow it from a colleague. It's the 4 fluids of life, and it doesn't include albumin. Now, that isn't to say that albumin does not have a role. It does have a role. We recognize that in acute on chronic liver failure, particularly, but in the setting of acute liver failure, I would put to you there is little evidence for its benefit. It's not harmful. I'm just not convinced it's beneficial, and it's immunosuppressive. So one needs to balance it. If you're using it at the beginning when you're immune inflamed, it maybe has a role. If you're using it later on when you're immune compromised, it probably has less of a role and may be detrimental. Feeding and GI management, there is little different from the average patient. If they tolerate enteral feeding, feed them. In the early stages, you must look at that in terms of arterial ammonia, and you must be cognizant that further stressing a gut with ileus is not good either for the gut or for your ammonia levels. So think of it as a holistic view. Always consider pancreatitis, both in terms of biochemical markers, but also sometimes in terms of axial imaging and considering that to make the diagnosis. You don't want to transplant someone with necrotizing pancreatitis. In terms of ammonia, the issues that I would draw your attention to are the role of the muscle in metabolizing ammonia, hence venous ammonia is different to arterial ammonia. It is clearly toxic to the brain with encephalopathy and risk of cerebral edema. And the kidney is really important in excreting probably about 20% of our ammonia load. So when you've got liver failure and an acute kidney injury, you have a double effect in terms of risk of hyperammonemia. You can clear ammonia. It's a water-soluble toxin. It clears very much in a linear fashion along with urea clearance. So hemofiltration, hemodiafiltration will all clear ammonia. And it is one of the few times where early renal replacement therapy is indicated in the control of hyperammonemia and deep encephalopathy. Thrombosis is something we've learned an awful lot more about. Having a high INR is not a reason to bleed. We used to be encouraged, certainly in some units, to give coagulation support. I think now with the recent work from various colleagues, that is no longer the case. We recognize that there is a procoagulant and an anticoagulant disturbance, and these patients have balanced coagulation. And you see here on these slides that balance, changes that impair hemostasis and changes that promote hemostasis. If you look at our patients with acute liver failure, you see the more inflamed they are, the stickier their blood is, their endogenous thrombin potential is higher than that for a control group. And again, this balance of pro and anticoagulation. So the only patients you might need to give coagulation factor support to are those with a really low fibrinogen and a picture of fibrinolysis on their thromboelastography. Cerebral edema, we've got much better at managing this. It is now vanishingly rare, and I apologize, I've left out a slide that shows that, but our incidence of cerebral edema has fallen considerably over the last 25 years. Hyperammonemia remains a risk factor, probably a cut point now of about 200 rather than 150, but that is still a reason to be concerned. And if you look at this here, this slide, the risks are deep levels of encephalopathy, being young, being unstable with an inflamed profile, having a high ammonia, having a low sodium, and being in renal failure. And what's important is how you respond to treatment. So if with fluid loading, with renal replacement therapy, with modulation of metabolic disarray, you see a fall in ammonia concentration, that's a good prognostic group in terms of risk. If the ammonia stays the same or goes up, that's the group you need to worry about, and that might be the small number that you need to progress to an ICP bolt. But even that has now changed. And we would now use transcranial Doppler and Dopplers to measure the optic nerve diameter as indicators of risk prior to putting in an ICP bolt. And as a big unit, we probably are down into single digits of these now. They are vanishingly rare. This shows you that as you get older, you are protected, your brain is smaller, there is more space within your cranium, so your risk of intracranial hypertension when you're less than 25 is probably about 38%. As you age, it disappears. And that was shown back in the 70s as well by a colleague called Ware. So how do you manage these patients? At the top here, you see the risk of developing intracranial hypertension over time. This is data of my colleague, Will Bernal, and you see that it is declining significantly over time. This is a function of multimodality interventions. We've talked about hypertonic saline, and we've talked about maintaining the sodium in the normal range and using early renal replacement therapy. Is there a role for active cooling and chilling of our patients? Probably not in terms of prophylaxis. In this study, if we looked at cooling patients in the bottom slides, between those who were at risk, they had an ICP bolt in, and those who were managed conservatively, there was no difference in intracranial hypertension. Keep this back for those that get resistant intracranial hypertension. Don't use it as a standard. You reap the side effects of infection and other things. And in terms of infection, antibiotic prophylaxis per se is not indicated. You risk stratify your patients, you monitor them, PCT, CRP, BDG, and you treat that high-risk population. I'm a short duration of antibiotic therapy at high dose, but there is equipoise on that, and others will think differently. In terms of who to transplant, the criteria of Clichy and King's continue to hold good if they are used assiduously in the way that they were designed. But as you can see, there are many other criteria as well, and all of them have variable sensitivity and specificity. What is also clear now is that these criteria are not as good as they were when they were first designed, in as much as we have got better at managing these patients medically. And my colleague Will Bernal looked at, certainly for the hyperacute paracetamol-induced acute liver failures, this was published a couple of years ago now, one should never consider transplanting someone who isn't in deep encephalopathy. Coagulopathy alone in this cohort is not an adequate reason for transplanting. And indeed, there is a view now that in hyperacute, the need for transplant is relatively rare. So apart from good intensive care, really addressing the details, does MARS or equivalent help us? Well, this study, which was the published evidence, suggests that there might be a small benefit, but this is not statistically significant. And therefore, at the moment, you would say MARS does not have a mortality benefit in acute liver failure. But I would draw your attention to the fact that these patients were transplanted within 16 hours of entry into the study. And as such, there's a question. We do know from studies of Harry Antonides et al. That the plasma of acute liver failure patients is immunologically anti-inflammatory. So if you take normal monocytes and you co-culture them with acute liver failure plasma and treat them with LPS, these are your healthy controls producing TNF. If you add acute liver failure serum or plasma to it, you don't produce TNF. You don't produce IL-6, and you produce more IL-10. So by the time you've got established acute liver failure, you are usually moving to an immune incompetent phase. If you remove that plasma using high volume plasma exchange, you can see in that cohort in bottom right here, who were not offered liver transplant, that there is a significant survival benefit for high volume plasma exchange. So this probably is something new now that we use as a standard of care now. It is less beneficial. There is no statistical benefit if you progress to transplantation, but it might be a useful bridge and useful for those who are not transplanted. And there is a rationale for it. It modulates your immune function, it takes out DAMPs and PAMPs, and it possibly also removes some of your procoagulant and microthrombi. This is an explanted liver of someone with paracetamol acute liver failure, and you see in red here all of the microthrombi within the liver. We know also from the work of Todd Stravitz that the microparticles, the thrombotic microparticles, are associated with organ failures. So in restoring normal coagulation with fresh frozen plasma, we might modulate this prothrombotic nature also. And of course, the main thing, and I'm coming to the end of the presentation now, that we must consider is that we should never live in history. All of guidance is written by definition historically. We've always got to push forward for our patients. This is a young lady who was found outside a nightclub in Brixton, part of London. It was thankfully the winter in London and it was very cold. She was fitting, but had a temperature of 41. We got seizure control. She was profoundly coagulopathic. She had very severe rhabdomyolysis. She had acute renal failure, acute liver failure, and hyperlactatemia. We were discussing whether she would need en-bloc transplantation. You see here all the air through her portal vein and in the wall of her gut. She was plasma exchanged, given standard therapies. This is her imaging on day 2, on day 11, and she left hospital without a transplant. It always pleases me when patients throw out the textbooks, and we should always give them the opportunity to throw out the textbook. This is a nice summary document published recently by Mark McPhail and Will Bernal. And again, I'm happy to share these slides with you, looking at the immune dysregulation in the pathogenesis of acute liver failure and where early plasma exchange may be beneficial. And so, in summary, Chairman, ladies and gentlemen, thank you for allowing me to talk to you this afternoon. I think things have changed. The etiology has changed. When my mentor, Roger Williams of beloved memory, first opened the liver ITU at King's, we were treating halothane hepatitis. I haven't seen that for 30 years. We were treating mushroom poisoning and hepatitis A. We are now treating some of these patients with ECMO to support them. We are using plasma exchange. We have got much, much better at working as a team and doing small things well. And those multiple small increments add up to a big improvement in outcome. Thank you for your attention.
Thank you very much indeed, Julia. Is perfect, is excellent presentation. I know that how long you take to in a LFU at King's, you set up all the trials, everything is incredible. It's very nice to hear you in our meeting today. And I think, Rita, you pass it to Adriano now. Can you introduce him, please? Your microphone is off. Can you put it on, please?
Okay. I have to thank Dr. Julia Wendon for his wonderful presentation and for showing not only the knowledge, but also his passion for the liver disease in ITU. So now I'm going to introduce Dr. Adriano Moraes, who is a doctor hepatologist in Sírio-Libanês Hospital in Brasilia, and doctor and gastroenterologist from USP, and have been working a lot with Professor Leila, and we have a very pleasure to stay with you, and the word is yours for the case presentation. Please, Adriano.
Hello, good afternoon for everyone. At first, I would like to thank for once again for this invitation to be here. And for me, it's always a big pleasure to attend this meeting. Once more, Dr. Leila, I would like to thank you for this big opportunity to learn a little bit more about liver transplant, especially about acute liver failure, and share the knowledge with my friends. So thank you very much for this opportunity again. The talk, it was about acute liver failure. So the point that you're going to discuss will be, what have you learned in acute liver failure of the last 25 years? The clinical case will be about a 35-year-old lady and her previous history with fibromyalgia and rheumatoid arthritis. She had no history of acute or chronic liver disease. In her admission in UCI, she got fever, asthenia, jaundice, itching, coluria, and fecal alcoholia. Her physical exam showed blood pressure 100/65, temperature 38.5, and heart rate 102. 5 days later, after her admission, she presented arthralgia, malar, and the whole body rash, drowsiness, and mental confusion 8 days after becoming jaundiced. She was hemodynamically stable, no vasoactive drugs, no active bleeding or invasive ventilation. She was used pregabalin, sulfasalazine, and duloxetine. She had no important epidemiology for leptospirosis, cytomegalovirus, or Epstein-Barr virus. Her blood, among other tests, showed transaminase with very high levels, up to, over 2,200 ELT and 1,200 EST, in total bilirubin 12, direct bilirubin 10.5, INR 3.6, factor 5, and the lactate, it was normal. Pay attention that all her hepatitis viral profile, it was negative, as well autoimmune diseases profile. Her IgM for cytomegalovirus, Epstein-Barr virus, and toxin resulted positive, although PCR for CMV, it was negative in that time. Pay attention that you just have the result, the PCR CMV results 1 week after the CMV IgM result. Her abdominal scan, CT scan, was almost normal, but she got hepatomegaly, splenomegaly, small ascites, no sign of portal hypertension. The brain CT scan, no brain edema, MR cholangio swelling, gallbladder, and no stones. Her SOFA criteria, it was 10, mild sodium 32, Apache 9, and Glasgow Score 12. She got a diagnosis of severe acute hepatic drug injury, cytomegalovirus infection, and dry syndrome. So, in summary, we had a 35-year-old lady, no cirrhosis or portal hypertension history, acute liver failure for drugs hepatotoxicity, inside King's College criteria for a liver transplantation, RNA over 3.5, etiology, drugs induced, and duration of jaundice of more than 7 days before onset of encephalopathy. She also was out of cliché criteria for a liver transplantation, but fortunately, she got better and she had recovery and normalization of liver function while awaiting for a liver transplantation. The questions for discussions are, the first one, how should we interpret multiple positive serological and autoimmune infection, serological and infectious market in this daily context? The second one, is there any criteria other than King's College or cliché to assessment acute liver failure subtypes? Third, is there any benefit in the use of acetylcysteine or intravenous steroids in intoxication by drugs other than DILI? And the last one, when to indicate liver biopsies and subacute evaluation. So we are open to discussion. I would like to listen our colleagues.
Okay, Adriano, thank you very much indeed. I pass to Professor Rita to introduce the debaters and Julia Wendon. Arun Sanyal, thank you very much indeed to organize. Everyone.
Hi. Good morning. Good morning.
Good morning.
Good morning. Welcome, Dr. Arun Sanyal. And thank you very much for being here. So now we are going to have the discussion of this very interesting case. And I have to invite Professor Roberto Carvalho Filho from São Paulo. He is an adjunct professor from the gastroenterology discipline from Unifesp. And also Dr. Lúcio Pacheco from Rio de Janeiro, who is chief of the liver transplantation unit from the hospital Quinta D'Or, Copa D'Or, and Copa Star in Rio de Janeiro. So he is a surgeon. And also we have Dr. Liana Codes from Bahia, who is gastroenterologist and hepatologist, and she was a fellowship in hepatology in Bourgogne, no Hospital Paul Brousse, na França, na University of Paris. So we have a pleasure to have the three debaters and also Dr. Julia Wendon and Professor Arun if he wants to participate. Thank you very much.
So I think if one looks at the evidence for DILI, and indeed many drug reactions, the role of viral precipitants is quite well described. Often the hepatic viruses are seen. I think in this lady, what's interesting is how immunosuppressed she was prior to this, in terms of functional immunosuppression and the potential role, although PCR was negative for both EBV and CMV from your presentation. So it's almost as though they perhaps are bystander impacts, contributing but not a main driver. I suppose in terms for me of the etiology, I'd also be interested in whether the sulfasalazine was a recent addition to her drugs versus a long-standing drug in terms of that history and time course, and whether she had a marked eosinophilia. I presume she did, given the diagnosis of DRESS.
Dr. Julia, if you permitted to have a question, because sometimes you don't have quickly the PCR for CMV, so quickly you have serological results. So sometimes you can delay the specific treatment for a real cause about the etiology. For in this case, maybe some you have in this context of DILI, you have some differences point a positive, false positive number and results like CMV or ABV. So sometimes you can delay to introduce the properly therapy. So how can decided in this time when you have 3 or 4 different positive markers for infection disease, how can you decide when I needed to decide I needed to treat the DILI or I needed to treat infection disease?
So I think in a situation where you've got this clinical phenotype, which from what you describe of an arthralgia, a rash, an eosinophilia, and a recent introduction of sulfasalazine, that is a very strong driver for me that this is the DRESS syndrome and that's what you're treating, and that the CMV is likely a bystander. I have to say, I am very privileged in the environment I work in because we get PCR back almost faster than we will get serology back.
Yeah. Yeah, can I add something to this?
Sure.
Hi, this is Arun. So hey, Julia. So I completely agree with Professor Wendon that in this case it's a very sort of a striking and relatively clear-cut case of a drug-induced liver injury. We have seen repeatedly, and I'd love to hear Dr. Wendon's experience. When patients come in with an acute injury, frequently you will have multiple serologic tests that turn positive. And we're asked by the house staff whether the patient has X, Y, or Z. I think the pre-test probability of having 3 simultaneous acute viral illnesses is very, very low. And over here, you have a clear-cut, picture that, as you know, with drug-induced liver injury, there is nothing pathognomonic per se, but in the right setting, all drugs have a classic picture of how they present with injury, and this clearly fits that. It is not unusual to have, and even we have seen IgM antibodies become positive, but when you have multiple of these, it's less likely that you're dealing with a specific infection. Remember though, but you do raise an interesting question, which is, we know that a certain proportion of our population has CMV, right? Chronic CMV. And whether you can reactivate CMV in a given clinical setting. But my personal bias is that in these settings, the primary source of injury, which in this case would be the sulfasalazine, which is the most likely etiology, that is going to drive the outcome. Normally with drug-induced liver injury, as opposed to classic Tylenol or something, outcomes are not as good, but I think she was a young lady and she got lucky and was able to turn around.
So I would absolutely agree with what you just said. I think the only thing that we see sometimes, and I don't know whether you do as well, is we see CMV reactivation at about 10 days, 2 weeks into a complex critical care course.
Exactly.
And then we track the PCR counts and treat at a certain level.
Exactly. The classic setting we have seen is a PSC patient who has ulcerative colitis, and they get a little CMV colitis acting up, but because they have increased bowel movement and blood and stool, their IBD doctor immediately hammers them with immunosuppression. And the more immunosuppressed you make the patient, the worse their CMV colitis gets. And then suddenly their liver numbers go off kilter, and then the patient is brought into the hospital. That patient is in multi-organ failure, and oh my God, what to do? And the simplest thing there to do is to stop the immunosuppression. But I don't know if you've seen those type of cases as well, but it's a good clinical pearl to remember.
Yeah, I absolutely agree with you.
Any further comments for my colleagues, Brazilian colleagues? Any further comments for this first question?
Well, just responding what Adriano asked about which therapy to start first, because the treatment for this would be the prednisone and antiviral. So I think if you have to start, you have to start both, and not very high dose of the immunosuppressor, right? And also, do you have also toxoplasmosis positive in that patient, or was only the herpes family virus? Adriano.
Sorry. Actually, we have, in the waste of the time, we will receive all the blood results. So we will make sure that we are in front of the real drug-induced injury. So because we have PCR negative in all other markets, in PCR were negative for this patient. But the question we have a doubt in that time, if we introduce steroids for dealing that time, because I know it's not so common to use steroids intravenous in that case, but we still haven't had the CMV results. So we had to start intravenous steroids before we had a result of the CMV. So, but actually he had no infection diseases actually. But we had just have 1 week later.
Yeah, a couple of things to remember is that, by and large for DILI, there are only limited indications for the use of steroids. So if you have the classic, with nitrofurantoin or something where it would produce an autoimmune hepatitis-like picture, and then here you have a DRESS syndrome with significant hypereosinophilia, etc. Those are very specific indications, but in general, we try to avoid, because there's really no good evidence that it makes a huge difference. Also, if you do use steroids in someone who is CMV positive, It's sort of like how you treat rejection. We will use a little prophylactic dose of ganciclovir or something in the background, just to make sure that while you're treating one problem, you're not creating another problem.
The point it was she had a very strong evidence of she had some autoimmune disease, because she had fibromyalgia and she had rheumatoid arthritis, but she had malar rash in face, and sometimes it was her diagnosis. It was confused with a lupus. So in that time, when we are desperate because her INR, it was increasing, we decided to do intravenous steroids.
Fair enough.
And I think, she was clearly a lady whose immune system was rampant. She was attacking everything she could attack. Yeah. So, I think you absolutely did the right thing in treating the stress syndrome with steroids in this context. Yeah. And just as was said, we would probably have just given her a bit of valganciclovir at low dose if she could tolerate it orally, or low dose IV if she couldn't, just as a backup until we got the PCR.
Exactly.
But do you think this time I was allowed to do intravenous steroids in that occasion?
Right. Can you move on to the second question, Rita?
Yes, please. The second question will be, is there any criteria other than King's College and Clichy for evaluating acute liver failure subtypes?
Now's the time for the surgeon.
Now's the time for the
Is that the time for the liver transplant? I think, I don't know. But if you have many donors in your country, if in your country, when you said, this patient needs for a transplant, and the donor, and I will be a donor in a few hours, I think that I can wait here to list these patients for the transplant. But here in Brazil is more hard than in England to obtain a liver donor. It's sometimes the patients wait some days for a liver transplant. Mm-hmm. And because of that, I think that I will put this patient in the list of the transplants at that moment. But if you have more donors here, I think that we can wait some days to decide if it's the time to put this patient in the liver transplant list. Julia showed many others forms to evaluate the patients with liver failure to indicate the liver transplant, but everybody in the world are completely no. You use it for many times the Clichy and the King College indicators. So I think that everybody that work with liver transplants are the Clichy criteria and King's College criteria are used for everybody. So it's easy to use. It's easy to think using these two criteria. But there's many others in the world. There are many others. Sometimes I saw the phosphato. If the phosphato it's low, I think that the liver is going okay. We can wait, but in general, you use these two criteria, and this patient have 3 criteria of King's College. He's a young lady. It's a good prognosis. You need to remember that every time.
Okay, as we have time to follow in 15 minutes, would Liana wants to give some words about?
I think I didn't. First of all, I'd like to thank Professor Leila Beltrão for inviting me here to be here. And I think sometimes you have a challenge to decide the best moment to do the liver transplantation. I think the subject of prognostic scores we can discuss about, because it's not so easy. I think it's complicated. I'd like to hear your opinion about what's the best prognostic score.
Well, I think that for listing for transplantation, we would follow the King's or Clichy scores. But what we are talking about, Dravet syndrome, in a drug that has hypersensibility, we can evaluate this patient with the His laws that can show us about the prognosis, that if this patient is not yet fulfilling the other criteria, is another form to follow the patient and to think if he and to feel if he has a prognosis to go for acute liver failure, depending on ALT and AST levels threefold upper the limit of normal, and bilirubin twofold upper the limit of normal, and not cholestatic, increasing in alkaline phosphatase and gamma GT, but it's only a form of to see the severity of the hepatitis. But for liver transplantation, we use the King's more often than Clichy.
Julia, can you comment, please?
So I think, as you say, King's and Clichy are well established and people know how to use them. I think what we all do now increasingly is, as was said by surgical colleagues, if you're in an area where liver grafts are rarer, you will often list earlier and watch, because you don't want to deprive yourself of that opportunity. The difficulty then is when you get offered a liver 6 hours later. I think in the context of this lady, what's interesting in the history is that, one, you were just starting treatment with steroids. So you've got that period of seeing what is her response to steroids and evaluating over the next 24, 48, 72 hours, what happens to the INR, her lactate, the other parameters. It's reassuring to me that she had a big liver. If she had had a small liver that was shrinking down, then I would be absolutely clear in my mind that she needed transplant. So I think it is that mixed modality. And I think if you look at some of the models that Will Banal and Indian colleagues are developing now, they are a bit more dynamic. So you could argue an INR of 3.6. We know there's variation in how people measure INR. You need to standardize it for your own laboratory and your own understanding as they apply to the criteria. So 3.6 is almost so close to the line. I'd have wanted to measure it a few more times, but probably reasonable to list and hold judgment.
Yeah, I think the world is moving towards a more dynamic assessment in real time in these patients, because so much happens and can happen very fast. And so instead of doing fixed time assessments, because, remember, these criteria were developed when we were young people and in training many decades ago. So the world has changed. So I think we evaluate these patients dynamically. And then, when an organ, and I think the principles were laid out beautifully by multiple people, so I won't repeat them, about listing and waiting. But I think when the organs do become available, then you have to make a decision. And there's a lot of work going on with quantitative liver function tests, etc., whether it's a breath test or it's based on microparticles, or all kinds of different things are in play right now to see whether you can actually predict the trajectory of the patient and then make a reasonable assessment about whether to accept an organ when available.
Leila, about the time, do you have?
No, you carry on. Move on for the third question.
Okay,
yes,
I think everybody agreed that this patient can be listed, but has to be in evaluation. And the next question is there any benefit in the use of acetylcysteine or intravenous steroids in intoxication by drugs other than DILI?
Okay, well, look, I'll do the N-acetylcysteine bit. I did the early bit of my career thinking N-acetylcysteine should be in the drinking water. However, I think it does have a benefit in acetaminophen. It has not got an evidence base in non-acetaminophen. Is it harmful? I don't think the evidence shows that it is harmful. It's an antioxidant. It gives you some glutathione. Is it something that I'd say definitely give? No, I'd say that there's equipoise. It's a good way of giving people sodium, but that isn't the easiest way of giving someone sodium. And I think steroids we heard about earlier, there's a very small number of drug-induced liver injuries, nitrofurantoin and the DRESS syndromes that are steroid responsive. Right. But others might have a different view.
Yeah, no, I completely agree with Professor Wendon that I think steroids may be a little overused in the community in the context of drug-induced liver injury. There are actually only very clear-cut circumstances where it's well established to be beneficial. And so, the benefit-risk analysis has to be done on a constant basis and reassessed on a daily basis, and sometimes even more frequently than daily. In this very, very fragile population.
In my group, I am a surgeon, but in my group, I think that they will start the NS2 sustainer because we went to the Pope's Hospital to learn about liver transplantation there. And there they use the NS2 sustainer almost all cases of acute liver failure. Yeah. But I repeat, I'm a surgeon.
Yeah.
I mean, I think the reality is...
Yeah. One thing to remember, though, is that one size does not fit all. So just this morning, I'm on the inpatient service right now. We have a 78-year-old lady who was taking for various arthritis, a bunch of medications, but they were all contained Tylenol. And so it was an accidental overdose. And that's 50% of the Tylenol overdose in the US now is this type of accidental overdose, unintentional overdose. And she was getting a lot of acetylcysteine, and that put her into a little pulmonary edema this morning that we were then having to get the fluid off her lungs. So, you have to just balance it out and look at each individual patient. I think the nice thing about having guidelines is it provides general direction, but I think one needs to be very careful that one doesn't become so prescriptive that it's the guideline and you just blindly just follow a guideline. You have to look at each patient individually. I'm sure you'll agree that, based on the individual patient's cardiovascular and other comorbidities, you decide exactly what's the best way forward and, keeping an eye on all aspects, that will impact the patient's outcome.
Absolutely. I mean, I think this is where we are now, isn't it? We have a reasonable evidence base, and we then need to use our clinical knowledge to individualize that care for the needs of the patient. It's personalized medicine that we need to move towards, supported by a generic evidence base.
Julia, apart from paracetamol drug-induced, have you done auxiliary liver transplantation in another case?
Yes, I mean, our surgical colleagues enjoy doing auxiliary transplants, so they've done it for acute Hep B. They've done it for some of the drugs. You really want to do it for the hyperacute acute group where you think you've got ability to regenerate. So, yeah, there's quite a few done.
Another colleague have further comments, or you move it to the last questions? Roberto?
Yeah, just first of all, thanks, Leila, for the kind invitation. It's a great honor to be here. I just wanted to emphasize that we need to keep to the evidence we have. And right now, we just don't have enough evidence to use NAC for every single acute liver failure case. So I just want to emphasize that we need to keep to the evidence we have right now.
Right. Angelo?
Last question, please.
Last question, then. When to indicate liver biopsy in subacute evolution?
Would you want to go for that?
Yes, please.
Okay, so look, I'll jump into that paddling pool and splash around a bit. I think the indication for liver biopsy in acute liver failure and I use that generically, is actually quite small. It doesn't give you good prognostic information. It carries a risk. Therefore, your rationale for doing it, for my mind, must be it is going to change my intervention or my management. For someone where I have got a concern, it might be infiltrative disease. I would always do a transjugular liver biopsy. But I would always want to give the rationale as to what am I looking for? Why will it change my management? Rather than I want to know how much necrosis, fibrosis, or whatever else I want to look at in terms of histopathology.
Yeah, I could not agree more. I think there was a period of time in the early 90s that there was this data that if you had more than a certain percent necrosis, it provided a prognostic information. But you can get the same type of prognostic information with factor levels and other ways of looking at the patient. So that has sort of fallen by the wayside. So unless there is something exactly like you're going to make a decision on steroids, that if you see something that looks like rip-roaring autoimmune hepatitis or something, that will tip you over to saying, okay, I'm going to blast this person with steroids. Remember, steroids are not benign drugs. And if you completely immunosuppress somebody with steroids and they're still getting worse and they go to transplant, now you've increased the risk of fungal sepsis and other things. So, we always have that debate whether to or not to. And so unless your treatment will be altered, you have to ask yourself, what are the diagnostic possibilities? Which one can I not make without a biopsy? And then how will that diagnosis change what I'll do? And then you have a rational roadmap to when to do biopsies.
I think this is not the time for the liver biopsy. I think the liver biopsy in subfulminant cases, some weeks after, if you're looking for a diagnosis, and sometimes to treat the patients, but not at that time, 80 days, and I don't know how the patient will stay in the days later. It's not the time. It's not the time to definition liver transplantation, but for the diagnosis some weeks later.
I'll tell you, our approach is that if you come in with an acute drug-induced injury and then progress into subacute liver failure, we will go ahead and list you for transplant. We'll go ahead and start planning on a transplant for that patient. Those people don't generally do well medically. Yeah. That's our cumulative experience of 30 years.
Yeah, I would agree. Particularly if they've got a shrinking liver, getting more ascites, deeply jaundiced. As our surgical colleagues in King's say, it's time for a big liver biopsy. We'll have the whole liver.
Do you have time to do a little question, please?
Yes, quickly, Adriano, because I have to move on to Professor Arun Sanyal talk.
We didn't speak about the ammonia levels. So, Julia and Arun Sanyal, have you been using ammonia levels like a factor prognosis in these cases?
No, we don't use it as a factor prognosis. We use it to determine
dialysis.
For early renal replacement therapy when they're encephalopathic. So it's a part of the multimodality monitoring, but it's not a prognostic marker in its own right.
Thank you.
Okay, I think it's wonderful. You could take it many times to be discussing, but I have to move on to the other talk. It's my pleasure to introduce Professor Arun Sanyal. He's a professor in gastroenterology division of Department Internal Medicine at the VCU School of Medicine. And is not only my friend, but he's trying to organize all the webinar for this year as well. And I have a good relation partners with our institute and the VCU University. Thanks, Arun, once again. And can you start your 15 lecture, and after you present the Angelo case report to be discussed in the roundtable today.
So thanks, Leila. Great pleasure to give this talk. I wish I was there in person, but hope maybe next year. Let's all hope springs eternal, right? So this is a talk about acute on chronic liver failure. And so this is a syndrome in patients with chronic liver disease, with or without previously diagnosed cirrhosis, characterized by acute hepatic decompensation, resulting in liver failure and one or more extrahepatic organ failure, associated with increased mortality up to 3 months. So important to note that this is distinguishable from chronic liver disease, compensated cirrhosis, and acute decompensation. And what I mean by that is first onset of ascites or encephalopathy or a variceal bleed. So if you think about the course of a patient with chronic liver disease, they go from a pre-cirrhotic state with chronic liver disease to compensated cirrhosis. Eventually, a proportion will decompensate. And once you decompensate, then you're on an accelerated spiral towards death. So at each of these stages, you can get an acute worsening. And this was originally conceptualized as ACLF A, B, or C, depending on where you started. If your starting point was pre-cirrhotic chronic liver disease, it's a A. And if you went to decompensated cirrhosis and an acute worsening, then it's ACLF C. The hallmarks of this syndrome is first that you have underlying chronic liver disease with or without cirrhosis, relatively acute worsening, systemic immune inflammatory activation initially, but later on suppression, worsening liver function, and the recruitment of extrahepatic organs. And so the classification currently that is proposed and sort of broadly accepted is that if you have ACLF1, you have a single organ. Typically, these are patients who have a renal dysfunction. It's a cirrhotic patient who develops an AKI, or it could be other single organ failure with a creatinine between 1.5 and 2, and typically it's with mild hepatic encephalopathy. ACLF2 is 2 or more organ failures, and ACLF3 is 3 or more organ failures. So also note that just having coagulopathy in a cirrhotic patient does not constitute ACLF, or if their INR just goes up by a few points, that does not constitute ACLF per se. That's just decompensated cirrhosis. Now, this classification is linked also to prognosis. So if you look at prognosis compared to people with no ACLF, if you look at their 28-day and 90-day mortality, you progressively increase the more number of organs that you involve. So if you go from 1 to 2, 2 to 3, there's a stepwise increase. And ACLF3, for practical purposes, has an incredibly high mortality. You're basically describing the final process of death rather than as some, early event per se. But ACLF1 and 2 do provide opportunities for intervention to turn the ship around, because there's still, we're talking about a significant possibility for a turnaround. Now, ACLF is a topic that generates a lot of emotion. As someone who's now, one of the great advantages of becoming a senior citizen is you can step back from the field and just look at the people duking it out and smile a little bit. But everybody, this is like many blind people describing the elephant, right? Somebody's got the trunk, somebody's got the tail, they're all describing the same animal. So there is an Asia Pacific Research Consortium, there's a European classification, and then there's a North American classification. And the differences and similarities are listed on this table that I'm showing you, but they all are trying to capture degree of liver function or dysfunction, renal function or dysfunction, neurologic function or dysfunction, the circulatory impact of this whole syndrome, and the respiratory, whether you have pulmonary or end organ involvement or not. So the PASL generally deals with most of these things without a respiratory component. The European, they have something for each, and there is a score you can come up with, and now there is a additional Cliff score that you can, ACLF score, where you can see what the score is from day 0 to 48 hours in. And, if your scores are still very high, then you have a high mortality. And then there's a North American approach, which is looking really at whether your kidneys have progressed to dialysis and whether you have advanced encephalopathy, need for pressors. This is basically focused more on defining the end organ failure in a more concrete way. So probably for me, the more important, rather than quibbling and arguing about whose classification is better, the important point is that this is a syndrome that evolves. It's a dynamic syndrome in each individual patient. And then you have to watch how the organ recruitment evolves. And from a practical perspective, what you really want to know is is there a precipitant, something that tipped the patient over? You have to ask yourself, why now? What happened? The person was doing fine. Why are they suddenly so sick? Because if you can identify a precipitant, it gives you an opportunity to intervene and try to turn the ship around. So what you see in this table is that if you look at the proportion of people without a precipitant, and even if you look at ACLF3, it's about a third, and in ACLF 1 and 2, somewhere between 40 and 50% of people, you cannot find a precipitant. So, but those are, remember, ACLF 1 and 2 are more likely to be a little bit of AKI type syndrome. Now, if you go to one or more precipitants are actually, that's much more common. So the party line really is that in the majority of these patients, you will find a precipitant. And particularly if you look at ACLF 2 and 3, 58 to 67.9% of people will have a precipitant. So what are those precipitants? One is if you're doing a therapeutic TAP, taking off more than 5 liters without albumin. Because you can induce something called post-paracentesis circulatory dysfunction. It is sometimes seen after a TIPS, particularly in patients with very high MELD scores. Remember, MELD was originally developed to identify prognosis after TIPS. So if you have people with very high MELD scores who get a TIPS, TIPS can precipitate ACLF, major surgery, acute hepatitis, and then, of course, worsening in a patient with alcoholic liver disease, if they had a binge and they developed acute alcoholic hepatitis. The monster in the room, of course, is bacterial infections from our perspective. At least in our experience, this is the one that is a really big deal. And then, of course, we are seeing a massive increase in the number of people with acute alcoholic hepatitis that we are seeing in the hospital, at least in the US right now. And so those are the two big ones for us. Depending on where you are, the profile of precipitants could be different, like reactivation of hepatitis B in places where hepatitis B is very common. There is always people who take Tylenol overdose accidentally or deliberately on top of chronic liver disease. But sepsis is sort of our main thing. So sepsis is important because even 10 years ago, this is very nice summary of the literature at that time, which shows that for last 20 years, there's been a progressive body of literature, which shows that sepsis is associated with a high mortality within the first 30 days. And then once you've had a bout of sepsis, your immune system is messed up and you progressively, it identifies a population of people at higher risk. So whether you had SPP, we've known for many decades, if you have SPP, your mortality post-SPP is much higher, which is why the whole idea of secondary prophylaxis and all of these things came about in the first place. Now we can say that across all systemic infections. The more sepsis you have, the poorer your prognosis will become. We know when you have sepsis, it produces all kinds of molecular changes within the liver. These are some of the transporters at the hepatic canaliculus. MRP2, bile salt export protein, they all get pulled back into the hepatocyte. So they're not where they're supposed to be. So bile salts cannot go through. Bile salts are required to make bile, to generate bile and for bile flow. So when you cannot make bile flow, you get cholestasis by definition. So as your cholestasis worsens, your jaundice will worsen and all of the other clearance functions of the liver will be impacted. So then you have a spreading ripple effect of dysfunction that is starting with one particular thing, sepsis, endotoxemia, and then progressive ripple effect across multitude of liver functions. So all of these things can go down and your bile salt levels can go up. And once again, these affect both the hepatocyte as well as the cholangiocytes. The other important thing that you have to think about is the immune inflammatory state. In the early stage, you get this period of immune activation. But then in the later stage, there is a period of where your immune system actually gets suppressed. And so you have a SIRS reaction, but later on you can have a CARS reaction where you actually, the patient is severely immunosuppressed. And this is one of the problems. You can't just give people steroids because you think their immune system is activated, because as patients move into immune suppression state, adding more immunosuppressants at that point only increases the risk of sepsis. This is the period where patients are particularly at risk for second infections. And so you have to think about all this as you think about your therapeutic strategy. Once again, from understanding the biology point of view, microvascular and endothelial dysfunction is central to this process because of all the inflammatory cytokines that are being released, and within the endothelial cells, activation of NF-kappa B and other pro-inflammatory pathways. And this leads to microvascular dysfunction, which leads to changes in cellular energetics and tissue hypoxemia. So while there may be oxygen in the blood, your tissues are really not being able to use that. At the same time, endothelial dysfunction leads to activation of coagulation and microthrombi. And then there are systemic endocrine changes and immune dysregulation, or you suppress. So all of this together creates the scenario where the patient is now set up to go into circulatory failure and multi-organ dysfunction. And then there's, of course, the idea of neuroinflammation also. Now, as the disease progresses, particularly at the high level, you can actually end up suppressing this whole cascade as you go into immune compromise. So once again, I'm quoting Professor Wendon, who's right here on the call. But this is a really absolutely fantastic New England Journal review that we use to teach our house staff all the time. But the classic one, in addition to the SIRS and the neurologic syndrome, is also understanding that there is a high output state. Many of these patients have cirrhotic cardiomyopathy, and there may be subclinical myocardial injury, which may be unmasked if you go overboard with the volume that you give the patient. The consequence of that is filling your lung up with fluids. And then there's this whole idea of acute lung injury that can follow. And then, of course, at the same time, there are liver-related dysfunction. Patients can get hypoglycemic. They can get lactic acidosis. Then there's hyperammonemia and coagulopathy that all of us recognize. And finally, this is over the last 10, 15 years, it's become very clear that adrenal suppression is a real thing that can occur in this population and may present with refractory hypotension in this population. And of course, all of these has an impact on how you perfuse your kidneys and whether your kidneys can maintain their normal function. There are other things like bone marrow, suppression, and the classic sepsis syndrome, where you not only have the SIRS criteria, but SIRS plus a possible source of infection, and then with hypotension that is unresponsive to vasopressors, and then full-blown shock and multi-organ failure. So the practical approach to management. So all of that is great theoretical construct. So what do you do at the bedside? So first question is, can you prevent in a patient with known chronic liver disease, particularly the cirrhotics, can you prevent ACLF? So in the setting of variceal hemorrhage, the use of prophylactic antibiotics. If you're going to take more than 5 liters off, give albumin 6 to 8 liters per ascites. If you're going to do a TIPS, really think about benefit risk analysis when the MELD is over 20. You got to really give enough thought for that population before you pull the trigger. It's not an absolute contraindication, but you got to think about it. And then in the setting of SBP, the use of albumin. Now, in Europe, there's at least a group of people who are protagonists for giving albumin on a regular basis. So there's a study where this was in Lancet showing that weekly albumin in patients with ascites on diuretics is associated with improved survival. In the US, this is not routinely done. There are other studies that showed that midodrine and biweekly albumin was not superior to placebo in preventing death, complications, or liver transplant in patients who are awaiting liver transplant. That was also published. So, it's not quite clear. And when you look at the use of albumin in non-SBP sepsis, this is another year of French trial, actually, with 193 patients. It really didn't have a significant impact either on all-cause mortality. And at 3 months, the proportion of people with renal failure were the same, while 8.3% of patients actually developed pulmonary edema from the albumin. Now, this year, we published a paper in the NEJM on the use of terlipressin in hepatorenal syndrome. And one of the things that has emerged now that we've done 3 pivotal trials with terlipressin is that with each trial, and especially in the most recent trial, there's an increase in pulmonary complications associated with terlipressin. And we have now done a deep dive, and we can clearly link that to the background use of albumin, which in some patients were getting 600 to 800 grams of albumin, while they were getting. So we in the hepatology community, we have pushed albumin so hard that I think we've gone a little overboard without really taking into consideration the individual patient's ventricular capacity to handle the preload. And there's another paper that came out earlier this year in the New England Journal from another British study, actually, showing that in cirrhotic patients in the ICU, regardless of why they're there, just giving albumin just because you can't think of anything better to do does not improve survival. And in the critical care literature, there is actually evidence that too much albumin may actually be associated with poorer outcomes. So you have to be careful. Albumin is a scalpel. It is not a mallet. So you have to be careful about how you use your albumin in this setting. So our approach to the management of ACLF is we look for a precipitating event and we reverse it, particularly focusing on infection. If there is organ dysfunction, we support that organ. And then, of course, we have to have a conversation about liver transplant. And then there are a few special considerations. So we think about predisposition, injury. So always part of that initial workup is look for sepsis, look for whether there was ischemia, if TIPS is in play, was there post-paracentesis circulatory dysfunction, is this chronic liver disease getting just a worsening of the underlying chronic liver disease, activation of hepatitis B, DILI, and then you look at the response, the inflammatory response, and then the number of organs that are impacted. Now, this allows us to then develop our treatment approach, which is shown on the following slide. So start with every patient gets a tap, you culture them, chest x-ray, get the lactate, treat the infection, use the antibiotic regimen that is appropriate for your center based on the bugs that are there and the resistance patterns over there. General measures such as fluid resuscitation, therapeutic tap if needed, aspiration precautions for the lungs, DVT prophylaxis, stress ulcer prophylaxis. If you have hypotension, use of vasopressors. And for persistent, after starting vasopressors, if you have persistent hypotension, you may consider use of stress steroids as well. So that's sort of our medical management algorithm. Probably the most important thing is if you think about sepsis, time to needle is extremely important. I think this is a very important paper which shows how important it is to start the antibiotics quickly if you suspect sepsis in your patient with advanced liver disease. Because you ideally want it within 3 hours, you need to have antibiotics on board in this population. So we are very aggressive. This is actually in my center. We use this as a quality metric for the individual faculty when we evaluate. When I do their annual evaluations, I actually look at this number to see whether they are where they are falling with this. Now, then there are other considerations. There's a lot of research going on, about lung support. We are all familiar with ECMO, especially in the days of COVID, but there are other issues such as respiratory dialysis, ventricular assist devices, and so on and so forth. And then again, bioartificial liver is a whole separate topic all in itself. And it's a field that it does 2 steps forward, 1 step backward, 1 step forward, 2 steps backward. But eventually, I think these are all the areas where we will see new things develop for sure. Now, transplant is a big deal because we always have a conversation. The question is, when do you get to that point where you can do a perfect transplant and the patient still does not survive? Because that's the argument we always have is, when do you get to the point where you cannot salvage the patient with a transplant? So infection comes up all the time. If you just have cholangitis or a liver abscess or SPP, and that's being properly treated, by and large, we think we can manage this and can move forward. If there's incidental bacteremia, we're probably okay. But if there's hemodynamically instability, or if there's worsening pneumonia, that gives us big pause. And we, often will have to make a case-by-case decision, of course. But usually with the worsening pneumonia, our answer is generally no. If you are on a single pressor or your need for pressors is coming down, we're good to go. But if you're going from 1 to 2 pressors to 3 pressors, that's probably not a good patient in our view. Again, a lot of this is clinical experience rather than well-designed studies, or what we would call hard data. If you have full-blown ARDS, we generally would say no to these patients. So Our take-home messages is ACLF is increasing. It's an expensive proposition, has a high mortality. Optimal management requires understanding of pathophysiology and reversible factors. Multi-organ dysfunction as a diagnostic criteria means diagnosis is too late to impact management. We really need better ways of finding that where the train has left the station, but before it has arrived at the other station. We got to give ourselves that opportunity to turn the process around. And liver support systems, for people with very advanced disease is an area that is undergoing a lot of study. Thank you.
Thank you very much indeed, Arun. As usually, very clear, your presentation. Now you move on to present Professor Ângelo Zamban de Matos.
So I'm going to present now our Professor Ângelo Zamban de Matos from Rio Grande do Sul, adjunct professor from the gastroenterology program and from the postgraduate program in medicine, hepatology at the University of Ciências da Saúde de Porto Alegre. So Professor Ângelo Zamban de Matos will present in 7 minutes the next case for discussion. Thank you.
Boa tarde a todos. Good afternoon. It is my pleasure to take part in this course. This is the case of a 50-year-old female patient with diabetes and dyslipidemia and overweight. She was diagnosed with cirrhosis during a hospital admission for pneumonia. She had ascites, jaundice. She was submitted to an EGD, which showed that she had large esophageal varices. She had a Child-Pugh score of 9 points, a MELD score of 15, a MELD sodium of 19, and a Aclf acute compensation score of 57. She was treated with piperacillin tazobactam, and she was discharged with propranolol and spironolactone. She was also referred to be evaluated for liver transplantation. She was not treated with albumin because, as you can see in this meta-analysis we have published, there is no evidence of significant benefits of albumin for extraperitoneal infections. At this point, she could follow one of 3 different paths. She could develop acute and chronic liver failure in the short term. She could be readmitted for further acute compensations of cirrhosis, or she could follow a more stable path. 2 months later, she was readmitted to the hospital with large volume ascites, jaundice, hepatic encephalopathy grade 1. She had mild anemia, she had leukocytosis, she had a creatinine of 1.6, hyponatremia, a bilirubin of 9.5, an albumin of 2.5, an international normalized ratio of 2.4, and a C-reactive protein of 80. The analysis of her ascites demonstrated 650 neutrophils. She had a Child-Pugh C score with 14 points, a MELD score of 29, a MELD sodium of 32, and a Aclf CAD score of 78. She was diagnosed with acute compensation of cirrhosis precipitated by spontaneous bacterial peritonitis and acute kidney injury stage 1B. At this stage, there is an important increase in mortality when compared to patients with stage 1A or to patients without acute kidney injury. She was prescribed meropenem and albumin, and she had her diuretics and propranolol suspended. But on the same day, she presented with hematemesis. She got worsened from her hepatic encephalopathy. Now it was graded as 3. She got hypotensive. She was admitted to the ICU. She was intubated for airway protection. She received volume expansion with saline. She didn't require vasoactive drugs except for telepressin. She received blood transfusion. She was already on meropenem, and she was submitted to an AGD. After the bleeding, she had a hemoglobin of 6, even higher counts of leukocytes. She had a creatinine of 2.9, a bilirubin of 12.8, and INR of 2.8. And on her EGD, she had active variceal bleeding, which was treated with endoscopic variceal ligation. She had a Child-Pugh score of 15 points, a MELD score of 38, a MELD sodium of 39, and a Aclf ACLF score of 68. She was diagnosed at that point with acute and chronic liver failure grade 3, precipitated by spontaneous bacterial peritonitis and variceal bleeding, and the transplantation team was called for consultation. We used the Aclf definition for ACLF because we understand it is more sensitive than other definitions to identify patients with poor prognosis, and we have demonstrated in this study that it performs better than the Nexel definition and the Asian Pacific definition regarding prediction of 28-day and 90-day mortality. We also use the Aclf ACLF score because it performs better than other prognostic scores for patients with ACLF regarding prediction of mortality, and we have validated this score in our population. On day 3 of her hospitalization, bleeding was under control, infection was under control. She had a mild general improvement on her clinical status. She had a Child-Pugh score of 14 points, a MELD score of 33, a MELD sodium of 35, and a Aclf ACLF score of 57, now being diagnosed with ACLF grade 2. On day 5 of her hospitalization, she was submitted to liver transplantation, which was followed by a long hospitalization complicated by fungal infection, but eventually she was discharged, and now she's alive and well. The questions we would bring for discussion are: how could we identify patients who will develop ACLF? What are the most promising specific treatments for ACLF? Either liver dialysis systems, such as Dialife, or interleukin-22 agonists, or stem cell transplant, or any other option? Should we recommend preemptive tips in patients with ACLF after variceal bleeding control? There's a recent paper published by Dr. Prof.ª in which he points that this population could benefit from tips, but it's actually a small and highly selected cohort of patients. And how can we achieve the best results with liver transplantation in patients with ACLF grade 3? Should we prioritize them over other patients? Thank you very much.
Sorry again. Okay, thank you, Professor Angelo. And the case is open for discussion, and we will have the participation of the panelists and the other inviters, Dr. Liana, Lúcio, and Roberto Carvalho. Can I?
Arun, can you start?
Yeah, maybe I can start. Yeah, I can start by taking the question about, preemptive tips in patients with ACLF. A lot depends on what you mean by preemptive, meaning what's the time frame. So I think while a person is in florid ACLF, particularly ACLF 2 and 3, that's not a good time to do a TIPS unless somebody is bleeding out and you're doing it as a last ditch effort to just save the patient. I would let the patient sort of get back to some sort of a stable baseline, reassess. And at that point, if they look otherwise okay, then I think it's reasonable to do it. But I would do it on a case-by-case basis, taking into consideration, what their liver function is, what they're starting. If you take a child class A patient who comes in with acute variceal bleed and has some worsening of liver function, maybe a little AKI, and then everything gets, you take care of the volume, the AKI gets better. It's not ATN, it's just a little volume depletion, AKI, hypotension, it all gets better. Hemoglobin is stable, you're banded. Patient has normal liver function 30 days out or 2 weeks out, that's a very different patient post-variceal bleed who had an ACLF than the patient who comes in with child class B, with prior history of ascites, maybe a little encephalopathy, who now has a bleed and goes into ACLF 2 or 3 with significant encephalopathy, renal failure, got HRS, and now you gave them terlipressin, you got them around all of that, and they're just very tenuous and now has a MELD of 22 baseline. That's a very different patient, so I think you have to be very careful with that. So I'll stop there and see if others have a different opinion.
I absolutely agree, and that would be what we would do. So if she'd bled again at day 3, she'd have ended up going down a TIPS line.
Yeah.
But otherwise, would have pushed her, as you did, towards liver transplant. But with that as the background, I think recognizing that TIPS certainly in Europe isn't offered as frequently as it should be for those patients who continue to bleed.
Thank you very much.
First question, Liana, can you answer the first question, please? And after Roberto?
About the predictive factors. First of all, Angelo, congratulations for your presentation. I think we have learned a lot of things with the Prestige study, but the study showed us that there are not predictive factors to identify who will develop the ACLF. Unfortunately, I don't think so. And the study described the different phenotypes of acute decompensation, but it didn't identify the predictive factors. It's the first question.
Yes.
Roberto, what do you think?
Yeah, well, the ACLF it's a matter of discussion all over the world. So I'm not that convinced that I could shock some of you, but I'm not 100% convinced that it's a separate entity that will have a specific treatment. So it's almost a sin to say that, but I'm really not that convinced. But in that sense, it seems since the canonic study, we know that, and as Professor Sanyal said, bacterial infections are the mainly problem in those patients, and we know that if you have an alcoholic cirrhotic patient with a bacterial severe bacterial infection with high CRP and high leukocyte count, that would be the patient you should be concerned, because the probability of developing ACLF is higher. So and as Professor Sanyal showed, it's absolutely paramount to initiate appropriate antibiotics as soon as possible. So I still believe it's not that complicated. If you have a very severe case of bacterial infection in a cirrhotic patient, you should pay attention that multiple organ dysfunction could arrive, and you should act promptly to avoid this endpoint. So that's it for this first question.
Yeah. Actually, Roberto, I agree with you completely. You're not shocking, at least to me. And I think this is in the US, at least many of my colleagues in the US, because I've asked this question. I told you in my talk that ACLF is a topic that generates a lot of emotion and heat as you go around the world. But at least when I go around the US, people tend to focus more on trying to say, let's identify the etiology that is going to tip this patient into trouble and then develop the therapeutic response based on whether the kidneys are going down, whether the lungs are going down, whether it's encephalopathy or what permutation thereof, rather than to say we have a specific treatment for ACLF2 versus ACLF1 versus ACLF3, acting like it's all one condition. They're not. It's very heterogeneous from one patient to the other, even within ACLF1 or 2 or 3.
And how can we prevent ACLF in alcoholic patients with no infection? For example,
stop drinking.
It isn't
Julia, you have some further comments? Julie, Reddy.
I think I love heresy. I've always been a heretic. I like throwing out tablets of stones, so it's lovely to hear someone agreeing. And if you think back of Andy Burrows, who was at the Royal Free, he was always of the view that ACLF was just a production, a description. And I have to say, I'm in agreement. It's a nice description. He always, and I discussed over coffee, we should call them critically ill cirrhotics when they get to ITU. But really, you need to look at the precipitant and the organ failing, and you need to address that. Can we work out who is at risk of developing an organ dysfunction? Well, I think it's because we're not very good at measuring organ dysfunction. So, if you have had a severe infection or a severe variceal bleed, you are likely to deteriorate again. The odds on it are. But what we don't do is measure renal function accurately. We all measure creatinine. We know it's a lousy marker of renal function. We don't produce creatine. So, we don't do GFRs properly. Similarly, we don't really look at cardiac reserve properly, and we have no great way of measuring true liver function. We measure liver blood tests. And I think we've got to get much more elegant about truly defining the risk of a patient by how well they recover from an insult. Do I have an answer? No, but I think it's a great way to carry on doing research.
Oh, that's good discussion. And
Angelo would like to,
Angelo, yes.
I would like to ask you if you don't feel we already have enough evidence of a more inflammatory setting in patients who have ACLF or who will develop ACLF, those now classified according to the PREDICT study as pre-ACLF, than in other patients with cirrhosis, such as those classified as unstable decompensated or stable decompensated, which have a more portal hypertension setting than inflammatory one, and that differences might be important in order to approach therapeutically these patients. I completely understand that ACLF is the extreme of acute decompensation, not another disease, but another situation of that condition. But it seems now that the pathophysiological explanation behind this particular moment of this disease is different than what explains the compensations in other steps of the natural history of cirrhosis. Don't you believe that?
I agree with you, Angelo. I agree.
Okay, so can I sort of challenge and agree?
Yeah.
Because I think we are all actually violently agreeing, but from slightly different perspectives. So I think the hyperinflammation has been somewhat overstated for acute on chronic liver failure. If you look at their immune function, they're very like acute liver failure. They also have immune suppression. So they vacillate between immune stimulation and immune dysfunction. That actually is very similar to someone with severe heart failure who's in ITU, or someone with severe respiratory failure or exacerbation of COPD. So I think what we're describing is a phenotype of ambulatory chronic liver disease, stable compensated maybe, a decompensation, and I would almost go back and say it's a critically ill cirrhotic with multiple organ dysfunction. We can call it ACLF 2 or 3. And by the time they are in that disease state, they will be both inflamed and immunosuppressed. And sometimes they will respond to plasma exchange. There's a study going on at the moment looking at that. And it's because it's my area of interest. I'd love to see us doing bedside immunological assessment of these patients. I don't think we do it very well. We use blunderbuss still. It's a bit like we were saying, we use steroids, we use this, we use that. We've got to become much more scalpel-like in our assessment of these patients and what we need to do in terms of intervention. Sorry, I'm talking too much.
No, this is perfect. Actually, I'm loving this conversation. So if I may add a couple of sentences to this is, so the first question is, in a patient with stable cirrhosis, what is the role of inflammation in predicting, identifying the subpopulation that will develop ACLS? So that raises additional slew of questions. How you define hyperinflammation, because, you know, I completely agree with Julia, that if you talk to people truly from the immunological world, they would tell you that at least in the existing published literature, how hepatologists, what they call inflammation, is really not a comprehensive assessment of the immune system. And there's some elements that are turned on, some are turned off. Given that the most common precipitant is a bacterial infection, and in the majority of cases, the source is from the intestine, you know, does it affect how that is linked to gut barrier function, or is it the barrier function? Is it just a surrogate marker that your gut barrier is already broken down? You know, those are the kind of pathomechanistic questions we need to answer to be able to relate, you know, with Jazz's work and other work that's been done at our center on the role of the microbiome in the precipitation. So we need a more precise sort of understanding of how that whether it is the inflammation itself that is setting the patient up for problems, or is the inflammation a surrogate that you're getting more bacteremic access to the body and understanding the biology of that process. Second is when the patient does develop ACLF, again, is the patient who has an ACLF from hepatitis B activation the same as a cirrhotic patient who took a few extra Tylenols, or is that the same as a person who, you know, ACLF patient who had a myocardial infarction, dropped their pressure and had ischemia, a NASH cirrhotic patient who had a MI and then had ischemia to their liver for 6 hours before they got the heart stabilized. The biology I would propose to you of these three distinct conditions are likely to be quite distinct, even though there may be common readout of the clinical phenotype. So that's where we need more precision in trying to understand the nature of the precipitant and the type of biology that comes from that precipitating event, so that we can individualize and personalize in that particular patient what is the best approach, rather than to lump everybody in, because that's just, in my view, and I may be wrong and I may be again in the minority, but certainly I believe that in this way, in this particular setting, we should be a splitter rather than a lumper, rather than lumping all the patients. And I agree with Julia that we all agree about the entity. We're all trying to describe this entity, but trying to get to a point where we can do the best thing for the individual patient at our bedside.
Right.
Angelo, thanks for your
again?
presentation. And I'd like to try to answer the second question. What are the most promising specific treatment for ACLF? I think that liver transplantation is for ACLF the same that liver transplantation was to acute liver failure some decades ago. And liver transplantation for acute liver failure can change the prognosis of the patients. And we need to change something in Brazil. In Brazil, when a patient in the UCI have a ischemic heart disease, the UCI doctors call the cardiologist, call the hemodynamicist. But when a cirrhotic is in the UCI here in Brazil, they not call the hepatologist. We need to change that. The acute liver failure patients need the hepatologist to define the best treatment and the time to the liver transplantation. optimal window for the treatment, the optimal window for the liver transplantation is very narrow. And you need the hepatologist in the UCI to define this with the intensivist medicine. We need to change this in Brazil. And another thing that you have in mind when you perform a liver transplantation to this kind of patient, the acute liver failure, that this liver transplantation will be too expensive. It's very hard to do a liver transplantation for acute liver failure patients with the fee paid by the government to the liver transplantation. We don't have any change of the fee paid by the public health for a liver transplantation for acute liver patients. The fee is the same for the liver transplantation from HCC patients. HCC. It's very, very different. They are very, very different surgeries. In almost of the case of acute liver failure patients that go into the transplant, we use the continuous hemodialysis in the operation room. The liver transplantation became very, very expensive. We need to have this in mind. We need the hepatologist in the UCI, and this transplantation is very hard. It's a challenge, but sometimes it's the same way that the patients becomes well after this hepatic insults.
Right.
I think it's the last question, Rita. The time is quite run out.
Right.
He has to go to see inpatient ITU now. You have 4 minutes to close this section.
How can we achieve the best result with liver transplantation in patient with ACLF3? Who wants to answer this question after all the discussion in a few minutes? Or I should close? Would you prefer, Leila?
Yeah, Julia, open the microphone.
So only just to say that I think we've described that it's identifying a patient who will have a good outcome post-transplant, and that won't be everyone with ACLF3. We can't just transplant everyone with ACLF3. We've got to understand that this group have a much more complex course, and they don't have such a good outcome as transplanting ACLF2 or ACLF1. So we just got to be cautious and look at that prognostic physiological reserve. We don't have a simple formula yet.
Lúcio, your surgery, how's in your team? How can you manage this?
It's a challenge, I know, and it's a very hard to in the post-operative. I think that it's not difficult for the surgeon, but it's difficult for the intensivist after the surgery. The only difference that you have at they use the continuous hemodialysis during the liver transplants. The anesthesiologist said that it's wonderful when you start to use the hemodialysis during the surgery. It's the only difference that we do in the liver transplant. But you need to know that the cost of this transplant is very high. It's very, very high.
Liana?
So
I think you can proceed with liver transplantation if there are no active infection and if there is no instability, hemodynamic instability. I think you can try.
Angelo?
I tend to agree with Liana, and I would like to hear from Professor Wendon what is the feeling that she gets from the recent experience in the UK of prioritizing these patients over others.
So
you have decided that the patient can go through a transplant, of course.
Yeah, so we can prioritize them, and that's good. We are enjoying that, but we are very selective about who we put forward for prioritization. So they have quite a rigorous assessment of critical care, anesthesia, hepatology to try, and I don't think we know how to do it, to assess their physiological reserve. So you don't want someone with poor peripheral perfusion who's been on ITU for 3 weeks. You need to choose your patient well for prioritization. The one concern I would raise that we are beginning to be worried about is what it does for those patients who aren't being prioritized. So we're having an untoward effect that was predictable, but we didn't think about it enough. So, you know, someone with severe portopulmonary syndrome or someone with severe biliary sepsis, they're just not hitting the MELD scores to ever go up the list. So we run the risk of having them present then and waiting for them to get septic and in ITU before you can transplant them. We've just got to watch that.
Thank you very much.
So,
any further comments, Roberto, or Rita, close the segment?
Yes, I can just make a comment. Living with all these very severe decompensated patients in liver transplantation, what I can see for the future of liver transplantation in ACLF3 is very difficult, as everybody agree. But I think we have to think about futility, how that is not yet completely established. And we have to focus on the futility for this patient with the ACLF, advanced ACLF. So we have already some signs that the patient is going to have a very bad prognosis, like if they are in mechanical ventilation at the time of the liver transplantation, if they are unresponsive for organ failure, extra hepatic, mainly respiratory and cardiovascular, if they have a very high lactate, more than 4, and if they are very older age, if they get a very marginal organ, so we are going to have a very difficult situation. So I think that ACLF, we have to learn much more about all the mechanisms involved to think that this patient can have higher mortality than an ACLF criterion without increase a lot of the MELD. So we have to go for a situation that they would be a special population that can have a MELD like the special MELD that we give for liver tumor and for lung hypertension and portopulmonary and ascites not responding, and also renal insufficiency. So I think it's very difficult at the moment we find the criteria, and I think that this discussion is very productive for us to think more and more about all the facts involved in ACLF.
Roberto, you have 2 minutes to finish.
Yeah, less than that. I think Professor Rita said something very important, and I don't think we'll have enough time to discuss this appropriately. That is related to the futility, applicability of those concepts of ACLF. And I'm very concerned about some colleagues that defends the idea of getting ACLF3 or 4 organ failures as a futility rule after 3 or 7 days of high intensive care, because it's very difficult to define what is a higher intensive care, and then we cannot just extrapolate between countries, because this this healthcare is completely different among countries. And I really believe that dynamic case-by-case discussion between all members of the staff and the patient families cannot be replaced by any number. Even those with 4 organ failures or 5 organ failures, they have around 10% 90-day mortality. So everybody can perceive those small survival rates as differently. So we must be very cautious about this this maths used so crudely. So I just want to point this.
I agree. It's case by case.
Yeah. Okay. I have to say thank you very much indeed to all my colleagues, especially Julia and Arun, that is spending the last 2 hours here. We have 505 participants, and I'd like to close this section to invite Luciano from UK now to close this section. Luciano?
Very good.
Thank you a lot. Thank you all the people from Brazil. Professor Lúcio for the surgery comments, our colleague from a long partnership also in Brazil in the surgery. And it will be a great pleasure, Professor Wendon, to be back here and follow a bit steps of learning together with you and the King's College Traditional Unit. And thank you, Professor Arun Sanyal, also for everything and the partnership and everyone. So hello and farewell from England here also. Bye.
Thank you, Luciano.
Thank you very much.
Bye.
See you soon.
Bye-bye.
See you next
Bye.
Tuesday.
Close the
Bye-bye.
section. Bye-bye.